There's a famous saying that all pain originates in the brain, which is a perfectly accurate, albeit highly simplified way of explaining what's happening on a neurological level when we experience pain. And although some people take this to mean that pain sufferers are somehow imagining or making up their pain, that's not it at all. What this actually is a small window into understanding the neurophysiology of pain, how pain actually works. And when you do that, it opens you up to a bunch of exciting and powerful ways for treating these types of problems. And this week, I got to sit down with a medical doctor with 35 years of clinical experience to talk about why she chooses to take a brain-based approach to treating complex chronic conditions. Let's get into this. Welcome, everyone. I've got a fantastic guest for you all today. Dr. Eleanor Stein spent 35 years in medical practice, focusing exclusively on complex chronic conditions like chronic fatigue syndrome, fibromyalgia, all types of autoimmune conditions, and of course, chronic pain. She brings a super interesting perspective to the conversation, and it's one that people suffering from these conditions really need to hear. Thanks so much for being here, Dr. Stein.
You're so welcome. Please call me Ellie.
Ellie, thank you so much. And call me Yoni.
Okay.
So I have to ask, 35 years in medical practice, I know you're recently retired, but it seems to me that most medical doctors don't approach the types of conditions that you're dealing with in the way that you do. So how are you working with these conditions, and did you learn that approach in your medical training?
Oh my goodness. I did not learn it in my medical training. I'm sure that will come as no surprise to your listeners and viewers. In medical training, we're taught, to isolate each symptom and each condition as separate from each other. And it became obvious to me early on that you have to look at the whole picture. So I kind of look at those diseases like puzzles, and they all have multiple pieces, and the pieces are things like, getting enough sleep, eating the right diet, getting the right amount and balance of activity, managing stress, managing mood, avoiding toxins, like really the big picture that's, of course, unique for each person. And that really is not practiced, I would say, in medicine, conventional medicine, at least in Canada where I work. So I learned it from my own lived experience because I've had many of these conditions for about over 30 years. And then from working with thousands of patients, you realize if you miss something, you got to go back and add it to the puzzle.
Yeah, it takes quite a bit of bravery, I think, to go in a direction that is so vastly different from what you're being taught in a very challenging educational situation. It takes a lot of bravery to go against that. Can you talk a little bit about how you arrived in that position?
Well, I think it was primarily from my own illness experience. So I became ill like pretty acutely and pretty severely in 1989 when I was in my second year of psychiatry residency. And I was so ill, I had to do my taxes that year. I had one thing, right? I'm a resident. I have one T4, that's what we call them in Canada, like one tax slip, and I couldn't figure out how to do it. So, it was pretty severe in terms of cognitive function and energy and dizziness and kind of you name it. And I quickly realized that the advice my doctors were giving me, although well-intentioned, was just falling way short. Like it was not helpful whatsoever.
So you're actually in medical school,
in residency.
So you're doing your residency. You're surrounded by doctors.
Yeah.
Experiencing all these symptoms yourself, and you're clearly seeking out, the resources that are around you, but you don't find their advice to be helpful.
That's true. And it took me about 10 years of searching, because it's not easy to find, before I stumbled upon functional medicine, environmental medicine, integrative medicine, right? So all of those kind of big fields, but on the periphery of conventional medicine. And that's where the whole world opened up, right? And I'm like, oh my gosh, there's actual studies and research. This is for real, because conventional medicine criticizes it and really dismisses these fields as being quackery or invalid.
Why do you think that is?
Oh man, I've been asking myself that question. I don't know. I don't know if it's just ignorance, like because they haven't been taught it. Like me, it took me 10 years to really find it and, you know, start reading and going to conferences, and kind of your head explodes at that point. I have a sense you went through a bit of a similar process where you realize there's this whole world of very useful, valid information that like is not even mentioned in training. So I don't know if it's power. You know, I can say that now because I'm retired. Nobody can come after me. Whether it's that conventional medicine wants to stay at the top of the power pyramid, or whether it's just ignorance, or probably a combination of the two. Because I had all those biases. Like when I went to my first functional medicine meeting, I mean, I was super skeptical, but then people started quoting paper after paper, and I'm like, oh my gosh, I mean, this is legitimate and researched and evidence-based.
Yes.
And it changed my world.
Yeah, it's so funny that you said, I don't know if it's power, and I can say that now because I'm retired. There's a quote that I'm not going to get right, but to paraphrase, it's something to the effect of, if you want to see who's in power, look at who you're not able to criticize.
Right.
So that's super funny, and I can identify with your process, because in chiropractic school, there was this really intense focus, at least from my perspective. You know, there's some choose your own adventure avenues there where you can go down, you know, a rabbit hole for this specialization or that specialization. But I was so focused on physical medicine that when we got to psychiatry, we had one class in psychiatry in chiropractic school, and I just blew it off. I behaved so badly. I'm so embarrassed by how I spoke to the teacher in that class, and she ended up being one of my favorite professors because of the way she handled my disrespectful outburst, and she completely twisted it around. And I remember I have this background in competitive martial arts and combat sports, and I felt like she mentally picked me up and body slammed me. And she did it so gently. It was graceful and beautiful. And I said to myself, my God, I want to know what this woman knows. And,
wow.
And that was actually a part of my postdoctoral training that really blew my mind and made my eyes go wide, like yours did a second ago. And I said, wow, there's this whole other world out there of more tools that I can put into my tool belt, and it doesn't invalidate any of the tools that I got in my conventional training. It's just more tools that allow me to help more people. And that when I started thinking of it like that, it was like, why would anybody close themselves off to that? It doesn't make sense.
Yeah, like in medical school, we got one series of 6 lectures on nutrition.
Yes.
And it was nothing about how to be healthy. It was just how to avoid scurvy.
Yeah.
Right. It was like, oh my gosh. And now, you know, I'm like fanatical about diet and how critical it is. If you don't feed your body the right food, how are you going to get and stay healthy?
Yes.
And it's totally ignored. You go to hospitals. I'm going to go on a rant here, Yoni. You go to hospitals. You know, my dad was in long-term care before he passed away, and the food was horrible. And you just think, how could anybody be healthy, stay healthy with not considering what we're putting in our body? Like, that's just one example of this, the massive oversight of conventional medicine.
Yeah, well, it's a disconnect is what it is. I remember going to visit a patient of mine in the hospital, and he had surgery to remove a very serious cancerous tumor from his body. And I went in to see him just after the surgery, and I happened to come in right when they were bringing food around, and I was like, what are you doing? was shocked at what they would feed a cancer patient. Just
Yeah.
mind blown. There's a total disconnect there. So I'm amazed by this because your training was in psychiatry. And I don't know how the practice is in Canada, but in the United States, the practice of psychiatry deals predominantly with prescribing drugs for mental conditions. And my understanding as an outsider looking in, and that's, I'm not an expert in psychiatry, is that even, and I have some patients who are actually psychiatrists, so this is interesting, but in speaking with them, the ones who do actual therapy are few and far between. It's become almost exclusively practiced in the realm of pharmacology. Is that how it works in Canada as well?
It's a little bit different. I think the way the medical system works in America, so financially driven that, and psychiatrists are, in terms of pay, they're at the top of the ladder, right? They're the most highly paid. And so there's this pressure to have them see people as little as possible and for as short a time as possible. That's my impression from the outside.
And that's just
in Canada, it's, yeah. And in Canada, it's a little bit different because we have, I got to be careful what I say here. I'm a pretty big advocate of public health care, so now it's out there. But we do have a lot more latitude. So I did psychotherapy my entire practice. That was my passion.
Okay.
My website before I changed it a couple months ago said psychiatry and psychotherapy, because you can't give someone a drug and not try to help them understand and solve the context within which the problem arose.
So well said. So well said, and foundational, really. Now, you branched off from your training, or rather incorporated a bunch of other aspects into your training. I know one of those aspects is a direct branch off of what you just said as far as understanding the context of an illness. And that fits nicely to the description that you gave earlier of looking at these complex chronic conditions as a puzzle and trying to assemble the pieces that can help these people put their lives back together, really. So I know a big part of that involves brain training. How did you arrive at that?
Oh, reluctantly. So a lot of what I've learned, comes from my own lived experience, right? I, of course, above all else, wanted to get better. I wanted my life back. Sure. And it was very clear to me, even working with functional medicine practitioners, naturopathic doctors, people kind of on the outside, that still they didn't have all the answers. So I realized early on, if I wanted to get healthy, I had to probably figure it out for myself. And so I've done, literally I have like thousands and thousands of papers in my EndNote, and I've been to hundreds and thousands of conferences, and just kind of integrating everything I pick up and then creating a program that includes, I guess you would call it the exposome. So that's kind of a new word to describe everything we're exposed to. We're exposed to stress, we're exposed to food, we're exposed to toxins, we're exposed to activity. So all of those things, everything we're exposed to impacts our health. And the fun part of my practice was for each person, because 10 people could come in who on the surface look like they have the exact same problem, say chronic pain. And yet the way they got there could be totally different for each person. Sure. So that's what I love. It's that kind of problem solving that we do in psychiatry. Like in psychiatry, we don't have any tests. So I'm, a lot of doctors are super uncomfortable if they don't have tests. I'm super comfortable with that, because that's the profession of psychiatry. You have to actually talk to your patients and listen to them and try to figure out what are those puzzle pieces for them that I'll call it the low-hanging fruit, that maybe they could tweak something just a little bit and it could have a very significant impact on their health.
That's awesome. I'm smiling because that's in so many ways the way that I look at things. Where can I find opportunities, easy opportunities to optimize, to optimize and improve this person's overall health status. And when you know what to look for, those opportunities really start popping out in all different types of places, which is neat because you might be working with a patient who's resistant to incorporating changes in one aspect of their lives. But if you try and work with another aspect of their lives, they're totally open to it.
Yeah.
So how does the brain fit into that approach?
Right. I get off track. That's one of my traits because I get interested and excited. So for myself, I was, working mostly with functional and environmental and integrative medicine strategies. And about 15 years ago, I started hearing about programs that were utilizing neuroplasticity as a tool for change. And I can describe what that means. I was extremely skeptical because I thought, my symptoms are hardcore biomedical symptoms. I have dizziness and weakness and brain fog and pain and like all this stuff that in my mind was very biological. And everything I had been doing up until then was biological interventions, drugs and supplements and, physical interventions. But then I got desperate. I wanted to go to Africa in 2014. I had very severe chemical sensitivity and I got put with a roommate who wore very fragrance products. And I thought, okay, I've got 3 months to figure this out because I really want to go on this trip. It was like the itinerary of a lifetime. And so I went and did a neuroplasticity based program and my symptoms got better within a week.
Wow.
Not 100%. That took, there was a bit of a tail there over the next year or two, but basically 90% better within a week.
That's amazing.
And I went to Africa and had no issues whatsoever with
That's amazing. But I have two questions. So you're talking about this internal struggle that you're dealing with where you're saying like, no, I have these biological symptoms.
How could a brain change?
Yeah. So explain to me what neuroplasticity is and why it was difficult for you to make the leap between what you were dealing with and that concept.
So neuroplasticity, plastic means moldable or changeable, and neuro refers to neurons, primarily in the central nervous system, the spinal cord, and the brain. So neuroplasticity basically means that the connections or synapses between our neurons are constantly changing. Whether we're aware of it or not, doesn't matter. They're constantly changing. So evidence of that is, say, a young child is learning to ride a bike. And the first few times there's, fear and falling and screaming and, it's very stressful, right? And the parents running alongside. The child practices and practices. The neuroplasticity is happening unconsciously. You don't have to do anything when you're a young child. It's just like on overdrive. And then all of a sudden, the child just rides the bike and stays upright, right? The brain changed. Something happened in the brain, and that's neuroplasticity. So neuroplasticity is the biology behind learning anything, learning to talk, learning to eat, learning to ride a bike, learning to play an instrument, learning to be a scientist or a chiropractor. Yeah. As whatever we do, say practicing the bike riding, the neurons that fire together at one time, so the child is learning to ride the bike and they're concentrating on going forward and this hand here and this foot here, and they do it a bunch of times, all the neurons they're using fire together. When neurons fire together, they actually send out little, like there's images of this on YouTube. It's so cool. They send out little dendrites or little arms, branches, looking for the other neuron. And as soon as they find each other, it's like E.T. for those of you who are of a certain age, and they hook on and they connect and they form a new synapse. Yeah. So what started out as a lived experience becomes hardwired biology.
Just explain what a synapse is, please.
A synapse is the connection. So you've got neuron over here and a neuron over here, and they both have 10,000 little arms. And those arms literally seek each other out. And as soon as they find each other, they create a connection, let's just say.
Sure.
It's like a circuit board. You're creating connections.
Beautiful.
And the more connections you have between those neurons, the easier that activity becomes. So for the child learning the bike, the synapses are forming, they're a bit frail, and then all of a sudden there's a critical mass and boom, they ride the bike no problem.
So
And that's
yeah. So what you're talking about here is so exciting, because I love the way that you described it. It's literally describing the biological process by which human adaptation takes place.
Absolutely.
And it's fantastic because it has to do with, as you said, learning, the acquisition of skills, the formation of habits, both conscious and unconscious.
Yeah.
And it has to do with something you said earlier, and I forgot the term that you used, but it was the summation of input into the system.
Oh, exposome.
Exposome. Yeah, I would term it as input. So all of
absolutely.
But exposal is the, you said it and I thought input. That's why I kept my.
Because people might hear that term, and so now hopefully it's basically, we have genome, that's all our genes, and we have metabolome, all our metabolites. So this is the exposome, all of the things we're exposed to that we're interacting with.
Oh, it totally makes sense to me. I hadn't heard the term before, but when you're talking about, say, going back to your example of riding the bike, so we have the muscular action that's involved in actually working the pedals, the muscular action that's involved in steering the bicycle, all of the balance and equilibrium stuff that's taking place. But then you also have the sensation of the wind in your face. You have the smells of your environment that's going on. You have the sound of your parents talking to you in your ear. And then you have all of your emotions that are tied into that. And all of that gets wired together for that exposal concept that you're talking about.
Yes.
Into that experience.
And that'll come in, like how you summarized it was perfect. And I'll just ask people, like, remember that, because when we shift over to chronic pain, that's exactly what happens.
So that's exactly kind of why I was setting it up that way. So how does the concept of neuroplasticity, how does that example of the bicycle experience fit into those complex chronic conditions and chronic pain, like the stuff that you've been dealing with for 35 years?
Yeah, that's a great question. So, of course, now I'm getting a little bit into hypothesizing, right? Because we don't have everything nailed down. What we do know is that neuroplasticity is why people get chronic pain. So that's solid, hard evidence, thousands of studies. And here's how it appears to work. So say you're riding the bike and you fall off the bike and you break your arm. I have a few friends, not kids, obviously, adults, who have fallen off bikes recently and broken their arms.
Oh, no.
So now you've got pain, that's acute pain. The signal is coming from, say, the broken wrist up to the spinal cord in the brain. The brain goes, oh, looks like there's a problem. They're called nociceptive signals. Noci is from the same word as noxious. So basically a warning, a signal's coming from the wrist saying something bad happened here. But there's no pain yet. This is like the key concept. The pain only occurs if the brain judges, using all of the input, the whole exposome, not just the signals coming from the wrist, that there's danger. So if the brain says, oh yes, I see the wrist, I see the blood, I see the scrapes on the knee, I see the bicycle lying in the road, I see the bone sticking out, whatever, it's gonna, in an acute pain situation, it's very quickly gonna accurately judge there's a problem. It fires up this whole fight or flight alarm system saying, danger, danger, do something, meaning hold your hand, don't put weight on it, get to the hospital, get some help, get someone to pick the bike up out of the road, all of that stuff. Pain is the brain's way of getting our attention to say, there's a problem, go solve the problem. But the brain, when it generates pain, it generates other things as well. It fires up cortisol, adrenaline, all the immune molecules, because maybe you got gravel in your hand and you need your immune system to be on alert for infection. all kind of different neurotransmitters and neuropeptides. So there's this big chemical soup that's released whenever the brain assesses that we're in danger. Now, in acute pain, that's great. That's exactly what we want and need to happen because we need to take care of the problem. Chronic pain's a little bit different. So the definition of chronic pain, say you had that broken wrist, it's now 2 months later, you get an x-ray, the wrist is good, right? The doctor's radiologist tells you the wrist is healed, and yet you still have pain. And I don't know the exact percentage, it probably depends on different circumstances, but a large percentage of people continue to have pain after the tissues have healed. And this is where neuroplasticity comes in. Why does that happen? It's because of exactly what you described with the whole exposure situation. So if when you fell off the bike, I don't know, maybe a police siren was going by and it startled you and that's why you fell, or someone almost cut you off and that's why you fell. So now you've got emotions and visions and sounds and the whole situation that was associated with the fall. That's all hardwired with those little synapses forming. So now it's not just that the wrist was broken, it's that there was fear involved and maybe anger and disappointment because you're already thinking ahead, oh my gosh, I'm not going to be able to work now because it's my dominant hand or whatever, right? So there's this whole kind of a bunch of associations that form. The signals that come to the brain, and the brain has to decide, does this mean danger or not? It's not only the signals of tissue damage because the tissues have healed, but all of the associated triggers can keep that cycle going and maintain chronic pain.
Yes. So I was just chatting with a friend of mine, and he was telling me about an experience where he, a year or two ago, he was working out very hard in the gymnasium. He had some particular fitness goal that he was working on, and he pushed himself so hard in a single workout that he gave himself rhabdomyolysis and ended up in the emergency room.
Ouch.
And rhabdomyolysis can kill you, as you well know. But for the audience, it's a condition where your body's releasing so much protein in the blood that basically your kidneys get stopped up, and it can kill you very quickly.
Wow.
So he had to go to the emergency room, and they resolved his condition, but it was a long, slow recovery process. And he found that when he would go back and try and exercise after this, and you already know where I'm going with this, start to get panic attacks.
Right.
It took him years.
Because it was hardwired, right?
It was
that's neuroplasticity. There's no other explanation. It's because all those synapses were created in that moment.
Yes.
And neuroplasticity is at its most effective, for better or worse, when there's focused attention and strong emotion. Mm-hmm. So that situation going to emerge, I'm sure, had his full undivided attention, yes. And he was probably really scared.
Yeah, he thought
so that was like the perfect setup, for really now having triggers that could potentiate anxiety or potentiate pain even after the biology is healed.
Yes. Yeah. So explain how that plays into a situation like fibromyalgia.
Well, of course, there's so much we don't know about fibromyalgia. The International Society for the International Association for the Study of Pain, IASP. So they're like the big fancy organization that makes decisions about what pain's caused by and what to call it. In 2016, they came out with a whole new category of pain. Up until then, we had acute pain and we had neuropathic pain, which kind of implies that the nerves themselves are damaged. And it was really problematic for people with fibromyalgia because they would often get told or read things that would lead them to believe that they had neuropathic pain because there was no other choice. They weren't acute, so they must be this one. And of course, it's a bit complicated because there is some evidence of some minor nerve damage in fibromyalgia, small fiber neuropathy. But in general, fibromyalgia is thought to be the poster child for a neuroplastic pain. So a pain that's caused by this learned association. So they came out with a new category of pain. It's called nociplastic. So noci means it hurts, it's noxious, and plastic means it's caused by neuroplasticity. There's a beautiful study that came out about a year ago, and it's a meta-analysis of imaging. So we have this thing now called functional MRI, where in real time, you can get people to think or do things, and you can see which parts of their brain light up. And it's so crystal clear that people with acute pain have a few brain centers that are processing that pain, and people with chronic pain, including fibromyalgia, have way more. So the brain is trying so desperately to solve the problem. It seconds resources from parts of the brain that are actually meant to be doing other things. The pain processing centers of the brain increase by up to 25%. So that's massive. It means neurons that used to be doing other things like thinking, exercising, enjoying life, they're now busy looking for danger and processing pain. And fibromyalgia, like all of the studies on fibromyalgia, really suggest that it fits into this new category of pain that's, I'll say primarily, because I'm not usually a black and white person, primarily caused by neuroplasticity, by the brain not getting the memo that the tissues have healed and staying in this autopilot pattern that there's a problem when actually there isn't. Now, I know some people are going to go, yes, there is a problem. I totally get it because I've been there.
Yeah. And we need to talk about that because that's exactly how I think about those conditions. In fact, I think fibromyalgia is more or less a completely worthless diagnosis. It should be called, nociplastic pain. I would be fine with that. Central sensitization, I would be fine with that because it actually describes what's happening, whereas fibromyalgia doesn't describe anything.
Fibromyalgia implies that there's something wrong with the fibers and the muscles. And yes, there is a small amount of evidence to support that, but the amount of evidence supporting the neuroplasticity connection is massive.
Yeah, the sense, when I first started learning about sensitization, I was like, well, that's fibromyalgia right there. The sequestration of resources from other areas perfectly explains why chronic fatigue would be associated with the problem.
And the way it gets into a vicious cycle is that you have pain, it's not going away, you become preoccupied with the pain. So again, pain is real and it's biological and it's measurable. You can measure it on these functional MRI studies. So I just want to say that it's not a psychological condition. It's not, people are whining or weak or anything like that. It's a real measurable biological condition. And it's caused by more and more neural connections forming to try to solve this pain problem that's out of proportion to what, the tissue damage that may be there.
It's such a good description. And the functional MRI that you're talking about makes total sense, that the body is using more and more resources to try and incorporate other areas of the conscious brain to solve a problem that it has determined is not getting solved by the resource that's currently. So it's like, I'm going to keep throwing more and more resources out of this and taking them from other places until it can get solved. But you get to the point where it's robbed a person of their energy, of their joy, of their, of their lives. Really, it's brutal. So let's get back to what you were just saying a second ago, where people hear this idea that all pain is in the brain and they push back on it because that statement is conflated a lot of times with some of the things that you just mentioned about, oh, you're just weak, or you're psychologically weak, or toughen up type of thing. And you really need to distinguish what's happening here from it's not made up. These people are not inventing it. They are very much in pain, but the brain.
And it's measurable. You know, in FM, there's hundreds of studies. It's real pain.
Yeah.
And you can measure it in the same way that you can measure someone that just got the elephant stepped on their foot. So it's absolutely real. And they didn't get into pain because of anything they did wrong. Neuroplasticity works under the radar. It's unconscious, right? The only way you can change your situation is through kind of understanding some of the things that we're talking about right now. And now, if you understand how the brain works, you can intervene and make conscious changes to your thought, feelings, and behavior to rewire your brain to heal.
So
but the people that end up in pain, it is absolutely not your fault. It's happening unconsciously.
Sure.
You don't even know what's happening.
It's like you can't turn off your receptors. They're working 24 hours a day, whether you like.
Exactly.
But now you're getting onto the very interesting side of this conversation where neuroplasticity functions as a two-way street. So the same thing that is creating what I often refer to as a pain habit, you know, with these chronic pain problems, can be used as a weapon to overcome chronic pain.
Absolutely.
So talk a little bit about that.
So the basic, the kind of the rationale behind why I'm so excited about neuroplasticity and why I'm now, you know, have been teaching it with my patients for about 10 years is because if you understand that everything we experience is due to these neural connections, and that you can change your neural connections pretty easily and quickly, like I did with literally within a week. I had chemical sensitivity my entire life. I have all the genetics for chemical sensitivity. Both my parents had chemical sensitivity. So I was really into this biomedical model of chemical sensitivity. I was not expecting anything to change. And yet it did. I still have those genes, the bad ones, that predispose me to chemical sensitivity, but I have no symptoms. That really got my attention.
Sure.
So what I did basically was I redirected. So every time I was experiencing exposure to some kind of smell that previously at an unconscious level ramped up my brain's danger alarms in exactly the same way as pain. I see the two conditions as quite similar to each other. I calmed my limbic system, right? Reminded myself that this is being caused by my brain. It's not a biomedical problem, or not only a biomedical problem. I'll get myself in heaps of trouble. And I actively redirect, meaning I focus my attention on something that I want to build and develop in my life, rather than focusing my attention on my misery. So even though I might have symptoms, and I had like a ton of symptoms, I was wearing masks to places, right? Because I couldn't go to like big social events. There would be, for sure, tons of people wearing perfume and stuff. So I was like pretty seriously affected. I remind myself that this is being caused by wiring in my brain. I don't need my limbic system to get involved. I don't want that danger alarm to go off, because once it does, it takes days to recover, right? Once you've released that chemical soup, you can't turn it off. It has to kind of work its way out of the body. And then I would focus my attention. So literally, I would walk back and forth in front of the smelly soap store at the mall, saying, wow, isn't that a fabulous smell? I feel so good. And maybe I would be remembering something great that happened in my life, or imagining something that I want to happen in my life that's going to be fabulous. So I'm shifting my state of being from danger to elevated mood.
So are you actually saying here, Ellie, that you recognized what was happening, and you consciously set out with the intention to wire in a new habit using exposal?
Yes.
So you went to the smelly soap store and you walked back and forth.
Talking to myself, and I'm a psychiatrist, right? So I'm thinking someone's going to stop me.
No, but
Mall security. Yeah.
That's why this is awesome. So you're saying it out loud. You're speaking the word. You're hearing the words that you speak as you're smelling it while you're constantly thinking of something pleasant. So you are creating your own exposal to rewire the habit that surrounds smelling strong perfumes.
Right.
Amazing.
And again, just to reiterate, just like chronic pain, it didn't happen on purpose, right? Like it's just the way my biology was wired. And then over time, so a hint that neuroplasticity is involved is that the problem gets worse and worse, and you start reacting to tinier and tinier triggers with more and more symptoms.
Sure.
So in multiple chemical sensitivity, this is the typical scenario. People get so sensitive that their partner comes home from work with maybe fragrance on their clothes.
Yeah.
And now that person needs to like change in the garage and go take an immediate shower.
And we should jump in here and say that this is not woo-woo nonsense, because how we would describe that in neurological terms is reduced threshold, because the body is desperately trying to get you to recognize something that it perceives as a threat.
Yes. And that's where the word sensitization, when the brain brings all these resources to play, more and more neurons to try to solve this problem, the brain is so focused on danger, it becomes more and more sensitive to tinier, we're very smart.
Sure.
If we can ward off a danger before it even happens, we're going to do it. So the brain becomes so focused on looking for danger that it gets good at it because of neuroplasticity.
Right.
And it starts picking up tinier and tinier cues and triggers. And then because of the associations that have happened, the danger alarm goes off and all the symptoms happen.
So that's super interesting, because there's a significant overlap there with the type of hypervigilance that you see with a post-traumatic stress disorder.
Absolutely.
And so you've got to say, like, many of the same brain centers are working in both of those conditions, and the overlap of the neurology between patients suffering with a chronic pain, fibromyalgia, central sensitization problem, and somebody who's exposed to a really traumatic event. There's got to be a huge overlap between the two.
And trauma is just a perfect setup for neuroplasticity, because remember I mentioned that strong emotion makes neuroplasticity, let's say, more effective. So if the strong emotion is negative, we also have this thing called a negativity bias. So our species evolved, those of us who are alive are descendants of people who had a very effective and strong negativity bias. They noticed all dangers. That's why they survived and we're here, right? The people who didn't pay attention to the saber-toothed tiger coming by the cave, they were dinner and they didn't have any offspring. So we've evolved this negativity bias, meaning we pay more attention to signs of danger than we do to positive things. And one of the strategies to shift habits, I love the word habit because it makes it sound very manageable, right? It's not using jargon or psychobabble or labeling people. It's just, oh, I got into the habit of pain. How am I going to change that?
Exactly.
I'm going to change my thoughts, feelings, and behaviors that typically happen when I experience a trigger and have a pain flare. I'm going to identify what those thoughts, feelings, and behaviors are, and I'm going to do something different.
Beautiful.
And ideally, I'm going to do something that makes me feel good. Because if it doesn't make me feel good, I'm not going to do it.
It's
consistently.
Exactly right. And that's exactly why I talk about it in terms of a habit. It's like, what in my life do I have control over?
Yeah.
And what do I not have control over? And with increased awareness, you start realizing that hey, I have a lot more control than I might have thought I had. And I have a lot of ways, as you said earlier, to identify where the low-hanging fruit is in my life that I can take advantage of. So talk a little bit about how somebody could do what you did with that chemical sensitivity and the problem with smelling perfumes and strong smells. And I want you to bridge the gap, if you can, between people who hear that and they think, oh, I'm just using the power of a mantra. I'm just willing myself to do it. And that's not what you're describing at all. You're literally talking about rewiring your nervous system,
right,
out of a habit that is negatively affecting you and into a habit that positively affects you. And I want you to hit home the point that as a person shifts away from that old habit to a new one, the body, in its amazing wisdom, will suck back up the resources, the pathways that were used to fire off that old pathway, and literally break them down into components and use them to build the new path that is actually benefiting the person long term.
That's absolutely correct. So the second law of, I talked about the first law of neuroplasticity, what fires together, wires together. And that's really the essence of how we end up with these problems. But the second law of neuroplasticity is when you make them, you break them. When you break them, you make them. So when you make new habits, the old ones physically break down exactly as you described. We have limited resources. We have limited, molecules in our body and brain. And if you're using them to do things that are life-sustaining and enjoyable, there's just not enough left to keep processing the pain. So if every time you have the symptom, say pain or chemical sensitivity, or say anxiety, because those really fit into the same rubric, you could identify, okay, what is your typical habit? So say for pain, it's usually to withdraw, to stop the activity because you're worried it's going to cause a flare. You usually get kind of depressed and sad and frustrated because your life isn't going the way you want and you're missing out on life. So those are the emotions. And then you might have thoughts like, this sucks. This is never going to get better. There's no solution. I've been all over the internet and it says fibromyalgia is a chronic condition for which there's no cure. So you've got thoughts, feelings, and emotions. Now, if you have a moment of awareness and go, I do not want to go down this path because every time I repeat those thoughts, feelings, and emotions, I'm hardwiring the problem even stronger. I'm going to change direction. I do this with my hands to show like I'm literally moving the focus of my attention somewhere else. Maybe I'm going to do a different action. I'm going to call a friend. I'm going to do maybe a gentler activity, something that I really enjoy. Maybe I'll do a creative activity. Maybe I'll meditate. Maybe I'll do imagery. Maybe I'll do a yoga tape. Like, the sky's the limit, right? There's literally thousands of possibilities.
You're just talking about something that makes you feel good.
Yes, and that's different than your normal reaction because you want to unwire, you want to break that habit, and you want to wire a new habit.
Yes. Yeah,
it's really that simple. Like I've had people hear that, put it into action, and a month later email me and say their pain is better.
So you're talking about, that's what you termed conscious redirection.
Yes.
So the analogy,
active redirection.
Redirection. So
as opposed to passive, sorry to cut you off because this is so important. So as opposed to passive redirection, also called distraction. So distraction does not work. And trying to talk yourself into, oh, I'm fine, I have no pain, totally ineffective. You actually have to do something differently. And neuroplasticity works best when we have our full attention on the activity and we have an elevated mood.
So that's huge, and that's really what I wanted you to hit home. So we're not walking in front of the soap store at the mall just telling yourself, this doesn't bother me, this doesn't bother me.
No.
So that would be a version of this that is ineffective.
Correct.
So talk about that difference a little bit more.
Okay. Our brain is not stupid. So if I try to tell my brain something that isn't true, so say I'm walking in front of the soap store and I'm feeling horrible, and I'm trying to tell myself I'm feeling fine, the brain is not going to buy it. It's too smart. So I have to get ahead of it. I have to first calm my limbic. I have to do a little bit of preparation before I walk in front of the soap store. I have to calm my limbic system. So I might do some paced breathing, a little bit of meditation before I leave for the mall.
Sorry, Ellie, we've talked a lot about limbic system.
Oh, what is it?
Explain what that is for
Right.
so everybody's on the same.
Apologies. So the limbic system is basically the danger alarm center of the brain. It's the part that notices danger. It goes, oh my gosh, we've got a problem. Fires up the adrenaline, the cortisol, the pain, heart rate, getting ready to run and save yourself. That's the limbic system. It's very trigger happy. It's a very primitive part of the brain, and it's easily activated. And in people with central sensitization, it's even a little more trigger happy than usual because it's had so much practice, right?
Yeah.
And anything we do often, we get really good at it. So if we get good at panicking and sensing danger, because we do it, if we do it often, we're going to get really good at it.
It's like a professional athlete who's done a sport a million times. They're so good at it. They're just practicing. The professional chronic pain sufferer is exactly the same thing. They're wired for that response.
They've practiced it every single day, multiple times a day for many years. And that has become their default because those neural pathways have become so strong. Nevertheless, I had chemical sensitivity for 45, 50 years, and it went away in a week.
Wow.
So I just want to really leave people with hope that even if you've had a problem, some kind of sensitivity problem, including chronic pain for decades, it can change pretty fast. Like if you go in very determined, and every single time you notice pain, you become aware of pain, you make the decision to actively redirect to something that makes you feel good and that's different than your habitual reaction, you will be surprised how quickly things will shift.
Amazing. So just a little bit more on the active redirection. So we're talking about shifting away from a pattern that is not serving you.
Right.
Actively taking your conscious mind and going somewhere else.
And doing something else, right? Like not just thinking about it, but doing something, because your brain has to be focused. It has to take your attention, which is why distraction doesn't work. So distraction, you're not really paying attention.
Very, very, very interesting. So and here's an example from my clinical practice where I take a person who's got chronic pain linked with walking or running.
Right.
And I get them walking backwards.
Oh, perfect. Because they have to really pay attention.
They've never done it before, Ellie.
Right.
They have no pattern that they can fall back
on. That's perfect.
So this is the kind of stuff that you wire in from a physical medicine standpoint when you really understand the way that chronic pain works neurologically. I just have to get them doing something completely different than they've ever done.
Absolutely. That's brilliant.
So this is why I love your approach. It just it hit me like a hammer. I was like, yes, this is amazing.
And another similar example is doing an activity you're familiar with, but on an uneven surface.
Sure.
So again, you have to pay attention.
Yeah.
Doing something on a wobble board or something where it's new and you have to pay attention or you're going to fall off.
But I love this thing that you're talking about with exposal, because another term that we use in functional neurology is summation. So we're going to layer in a bunch of different inputs on top of each other. So I might get them backward walking and then doing something with their hand, or counting down from 100 to 1, but skipping every 3 numbers so that they're really focused. And you can take a person with chronic pain whose shoulder doesn't move, and you can get them doing all these things that they've never done before, and all of a sudden their shoulder moves. Because
I've never really heard of that approach, but that is a great example.
But even never hearing of it, you can understand the neurology behind why.
Absolutely.
Yeah. So there's so much overlap between what you're doing and what I'm doing. I find it absolutely fascinating. I got to get you back for a round 2, but tell the audience where they can find out more about what you're doing, because I know a lot of people are going to want to hear about it.
Sure. So I have a website. It's www.eleanor, Eleanor Stein, STEINMD, like medical doctor.ca.
That's awesome. I'll put a link for that in the description underneath this video. Thank you so much for coming on, Ellie. I'm going to get you back for a round 2 in the near future.
If you enjoyed this interview and you're looking for more information on neuroplasticity, Ellie has prepared an awesome handout with 7 simple tips for living with less pain. You can access that by clicking the link in the upper right-hand corner of your screen. I'll also put a link for it in the description down below. Beyond that, I just want to thank you so much for watching. Make sure to hit that thumbs up button before you head out of here, and I'll see you next time.